All right. We have a Thursday on the books, which means we have a couple of studies to get through. Not too many came across my docket this week, so there's not going to be that much to say, and most of them are pretty straightforward. So first up from the International Journal of Orthopedics, concomitant sacroiliac joint abnormalities in patients with femoral acetabular impingement. Put another way, if there is a patient who has a deformity of the hip, not uncommon, mind you, do they also have an SI joint abnormality as well? And this one they found, yes, actually, there is a fairly high chance that you will have some sort of concomitant condition if you have FAI. And when we kind of talk about it, it's going to make sense. So what did they do? They reviewed data from 8 studies with almost 2,000 patients and found that the prevalence of sacroiliac joint abnormalities in patients with femoral acetabular impingement can be as high as 25 to 28%. So basically 1 in 4. So for every 4 patients that walks through my office with a confirmed FAI, whether it is an issue with the ball of the ball and socket, where instead of a smooth round ball that can articulate really nice, maybe it's now more of like an Hey Arnold football head or Stewie Griffin. It rolls, but you kind of hit a couple of points where it doesn't like it. It's not as smooth. It doesn't matter if it's cam deformity or pincer deformity. So now it's the socket part where the socket now has extra bony growths that are kind of impeding the actual movement of the ball and socket joint. So for every 1 in 4 of those that walk into my office with one of those types of femoral acetabular impingement deformities, I can roll the dice and say one of you 4 also has some sort of SI joint abnormality. All right. And that can be confirmed typically on further imaging. But let's continue to see what the study says. So furthermore, the prevalence of femoral acetabular impingement morphology in patients with axial spondyarthritis, so that is typically think of it as an inflammatory arthritis, usually of the spine, can cause some chronic back pain, can be as high as 20 to 37%. Now, finally, patients undergoing hip arthroscopy, oh man, I cannot talk today, arthroscopy for femoral acetabular impingement, so they're actually trying to get it taken care of surgically, with axial spondyarthropathy and or SI joint abnormalities, here's the big thing, have lower postoperative outcome scores reported compared with those who do not have the comorbidities. So from a clinical standpoint, we can really actually set up some expectations and prognosis and give these patients that may still require the surgery, even though it's not necessarily as good of outcomes, we can essentially put them in a better headspace through recovery by giving them a more personalized prognosis. So rather than, hey, 40-year-old male patient who's still trying to maintain level F athletics in my office, yeah, you have FAI. Yeah, it's pretty bad where we can't do that much conservatively anymore if you want to still do activities A, B, and C. If you're going to go to surgery, we should also just double check and see if you have any of these other comorbidities, other concomitant conditions. Because if you do, then we have to change how long we're going to want you to recover and what the expectations post-surgery are going to be. Because if they have a friend, colleague, or do their own research, they may be expecting, oh, I can probably play again, per the guidelines, which off the top of my head, post-operatively, they're all different. So I don't know, like, I'm going to shoot from the cuff. Let's just pick a number. Let's say it's, 4 to 6 months post-op with healthy PT, you can have a relatively high level return to athletic endeavors for this condition. And this person now gets the surgery. Well, they're at month 5 and they're maybe 60% of the way there. They're not going to be happy. They're going to probably start to spiral. You're going to have to now deal with more potential issues post-operatively that they didn't anticipate, and they may have a worse viewpoint of the decision to go through surgery because they didn't have appropriate expectations going into it. So the worst post-operative outcomes we shouldn't necessarily look at it as something to guarantee avoiding surgery from the first place. I'm not saying we shouldn't, greatly rule it in. Like, yeah, worst postoperative outcomes. Maybe we hold off as long as we can, like even longer than we normally would. But it should also be looked at as something where, hey, yeah, people with your additional conditions don't have as great of outcomes. But if we know that going into it, we can plan ahead and set goals rather than in that 4 to 6 month period. Let's set them for 9 months, maybe 9 to 12. Let's lengthen out the recovery time. Let's also say, hey, rather than having 80% pain reduction and 70% improved range of motion, let's knock some of those numbers down so that we have a better likelihood of not a better likelihood, will alter what the patient's perception of success really is so that they're not disappointed by results that aren't necessarily as attainable to them, so that the post-operative outcome is more meaningful when we actually get there with a better set of expectations. That was a very long-winded way of saying, let's go for a more guaranteed result and outcome by setting realistic expectations than potentially shooting for the moon that this person may have the deck stacked against them going into it in the first place. So what do they conclude outside of my rambling here? What we just talked about. Quarter of patients with FAI can have concomitant radiographic SI joint abnormality. So it's something that they can confirm. It's not, I have symptoms or not. It's like, no, it's on there on the image. And they cannot overemphasize the importance of assessing the spine, specifically that SI joint, and ruling out symptoms emanating from that joint in all patients with FAI. So like we talked about last week with SIJ pain, hey, we have to now also look at the TL junction. Hey, patients with FAI, we should also, hey, look to the low back SIJ and basically everywhere else. It's really highlighting that, like last week, don't get so myopic in your diagnostic viewpoint that you completely rule out other contributing factors that this person can go through. It's what makes, all right, I'm tired enough, I'll throw in the cliche. It's what makes the practice of medicine practice and not the guarantee, is because we can get so focused in that we don't see the big picture. And this whole clinical healthcare experience is so complicated because we're dealing with people and individuals, which we could talk about so many things. The mental aspects of patients' expectations going into healthcare, what results they want, their physicality, their chemistry, their genetics, their environment, their culture, their background, like all of these things legitimately play a factor in pretty much every facet of medicine, whether we want to, admit it or not. So it's not just, oh, mental health, that's only for the psychiatrists and the psychologists. No, they're the ones who, should a person have a condition, certainly be, in charge at the head of that condition process. But everybody else has to be aware that it is a factor in whatever else this person is going through. So if they have concomitant, chronic low back pain, as somebody who at least has an expertise in chronic low back pain, I also have to be aware of mental health playing a factor into it. Same thing if you have a general practitioner, family practitioner, seeing a whole myriad of different diseases, whether it is screening for diverticulitis or other cardiovascular diseases. They have to be aware that it's not just the pathology. They have to be aware of, like, wait a minute, is there other things that I need to be aware of? Like, all right, cardiovascular health is really, really tied to oral health. Do we play the chicken and the egg? Like, maybe I need to send that guy to have their oral health checked by a specialist. We have to be able to understand and view the person as a full picture, be able to diagnose and treat what is in our wheelhouse, and screen for what may come up consistently for the things that we're treating commonly in the office, and then refer them out as necessary from there. This is just me tying point A to point all the way to Z, not A to B. We're going all the way to A to Z. I know we're only talking about hips to pelvises, and last week we were talking about upper low back to pelvises, and now I'm coming out of left field going, no, we have to really screen for all of these things, which is still true, but I'm rambling at this point. I'm going off topic. It is talking about hips and pelvises, the relationship. You need to look into it, concomitant comorbidities. It's really just, said another way, in more broad terms, just look at the whole person. They have a focal hip issue, take a look at the hip, but also then look at other things too. Moving on. I promise the rest of these are a lot shorter, except for the last one, because I want to talk a little bit about that. What components of rehab interventions are more effective to reduce pain in patients with cervical radiculopathy? So we actually have something that is encroaching upon neural tissue, leading to symptoms away from the site of the lesion. So radiculopathy, oh, I have potentially a cervical disc lesion, and now I feel symptoms going all the way down my arm, maybe in a fairly easily traceable path. So this is a systematic review and meta-analysis. What did they find? We can actually jump to the plain conclusion for this one, and it's what we've seen before. A combination of articular treatment, so taking care of the articular structures, so the joints, so joint treatments, typically in the form of manual therapy, which can include spinal manipulative therapy, analgesic electrotherapy, neurodynamic techniques, so actually getting the nerve roots to move in a controlled manner, a tolerable manner, strengthening exercises, and cervical attraction appear to offer the most effective pain relief for patients with cervical radiculopathy with a fairly moderate confidence rating. Not bad. Now, individually, so when they looked at each actual treatment as a single unit, neurodynamic techniques, cervical traction, and the articular treatment, so again, taking care of the joints and articulating structures, were the components associated with significant reduction in pain. Awesome. Although dry needling showed encouraging results, its limited presence in the network prevents drawing firm conclusions about its effectiveness. Basically, more studies need to be done to back up the first sites as to what it's doing. So first impressions, basically. Initial impressions from this meta-analysis is, hey, dry needling could be something useful like the rest of these things. We just want more evidence so that we can confidently say it, at least from a systematic review standpoint. There are individual studies that back up what this meta-analysis saw, because it's a meta-analysis and systematic review. It has to pull from other sources. So it's pulling from a few. When they're just adding confidence to it, like how much can somebody stand out on an island and say, this will do what I say it does, they're not quite there when it comes to dry needling. Again, we're going to go back to the art of medicine. There are a bunch of studies and a bunch of cases that do show that if we include it in certain conditions for certain patients, ergo the right person with the right treatment at the right time, dry needling can certainly be effective. But like the rest of this study is showing, it's not something that I have to myopically focus on. Again, I have to be able to piece out and have a conversation with the patient of what do I think is going to be the most effective treatment for this person at this time. If I have a bag of goodies to pull from that have similar results, then I get to basically match it to the patient and the condition in front of me. Some may fit better than others when it comes to these puzzle pieces. Like, yeah, no, this one, I have a little bit more evidence to show that what you want and what I want out of this may warrant more dry needling over other modalities. But outside of those individual circumstances, we can then pull and show, hey, multimodal care works great. Spinal manipulative therapy combined with manual therapy in the form of instrument assisted work is great here. For different conditions here, yeah, we can poke with a needle. We're showing some pretty great results and pretty great results with cervical radiculopathy. So just highlighting and backing up what we already do in the office, treatments that we already utilize in the office for conditions that we pretty commonly see in the office. So I frankly like this one. It tickles my bias. So next, effects of combining manual therapies, neck muscle exercises, and therapeutic education, pain, neuroscience in patients with migraine. I'm going to cut to the chase. It says the same thing as the last study, but with migraines now instead. Multimodal care is the best. Don't just rely on a single form of treatment if you can help it. Or if that's what you specialize in and all you're comfortable doing, have a branched provider approach. Because again, it's not that I'm not saying that all providers have to be able to do all things. I'm saying the patient has to be the one who's going to be, or who has access to all of these clinical approaches for the best outcome. So we can either find clinics like mine and several others that I know that are able to do it all in-house and keep the provider pool limited to really have a more intimate approach, and intimate in the sense that I'm really the one taking it from point A to point Z, and I know the entire course of this care, and you're not going to be bounced back and forth between 5 different providers who may or may not be communicating efficiently. But what I am saying is that if that is not available, then just find or work with other providers that fill in the gaps for your patients. So this one does it pretty well when we actually review it. Multimodal treatment yields better outcomes for migraine and neck. Pain education improves the questionnaires that they were using to assess their headspace going into it. And manual therapies reduce the headache impact in the first month of treatment. So it all has a place and it all does different things. And because migraine, if we take people, what I've been already talking about, people are complicated enough, migraine is a mechanistic approach. What do I mean by that? Well, is it vascular? Is it neural? Well, it's neurovascular. There's also additional chemical components. It is its own thing. There are clinics that do only migraines, and they only see migraines and only treat migraines because there's so many different components that go into it. So it makes sense that if there's so many different components that go into, different people have different types of migraines with different symptoms and different pain levels and levels of disability, that you should probably take a multimodal approach to care, because the odds of just a single treatment or a single type of treatment having a huge benefit for the wide slew of migraines out there is slim to none. Rather, have a whole bunch of tools available to help whatever patient walks through your door with that condition in the first place. All right, we're almost done. I'm going to take a sip. All right. Now, this one's a bit different. This one is essentially a review. So risk factors and injury prevention strategies for hamstring injuries, a narrative review. So they go through and they just kind of see what is the current state of evidence for whatever it is that they are looking. What is the risk factors? What are the beneficial treatments so far? And this one is talking about hamstring injuries. These reviews are basically fully narrative. Like, this is a pretty long, like, here's the introduction, risk factors, like it's going through the entire pathoanatomy, what happens. Here's the biceps femoris, or one of the hamstrings, and aponeurosis. It talks about the anatomy of the condition, strength ratios, flexibility, age, all these different risk factors that it peruses when we're discussing this injury. So I'm going to skip all the way down, just for discussion purposes, to the summary part. It's not saying that much that we don't know, at least by observation. Because what do people hear all the time if you're running, sprinting? Oh, I pulled a hammy. So it's pretty common. So to that effect, hamstring injuries are prevalent in high-speed running and kicking sports, representing 12 to 26% of all injuries in sporting activities. So very, very common. And because it's a high incident and recurrence rates, it poses a significant challenge. This review identifies key risk factors, which, if you didn't know, now you will. It includes things such as previous hamstring injury, which is essentially one of the biggest prognostic factors for any injury, is previous injury. So what is a prognostic factor for ankle injury? Previous ankle injury. What about shoulder injury? Previous shoulder injury. So this one is kind of the no-brainer, but let's go on. Neuromuscular deficits. So that doesn't have to be a neurodegenerative condition. That could just be people having a comparative controlled, no, let me rephrase this. Compared to a standard, people don't have as good coordination or balance when they're assessed against somebody of their peer level. So it doesn't seem like they're coordinating movement as efficiently compared to the rest of the group being tested. Muscle flexibility, um, muscle imbalances when they actually like test it out, um, age, anatomical variations, and they just kind of highlight a few factors from here. So notably that neuromuscular control and altered muscle recruitment patterns significantly impact injury risk. This is one of the few points where I actually will open up a discussion on this paper. So what do we do about it? Do we just train balance? Do we train these things? I'm not going to say no, but I want to put a different spin on this that may make it more relevant. This actually, to me, really, really, really highlights the need for athletes to go through an adequate recovery process. The reason being is we could be pounding the dust doing all these sorts of fancy different exercises, motor control drills that legitimately may or may not actually be benefiting the patient at the time. Rather, things that I know impair these factors are things like not getting enough sleep, not getting adequate nutrition, not getting enough time to you're essentially not putting as much effort into recovery as you are into the effort of sport itself. That's where a lot of these will creep up. And all of a sudden you're not grooving the pattern. You feel off. Things aren't as coordinated as you want them to be. And with athletes who are as in tune with their body as pretty much anybody you're going to get, these subtle shifts, because they've had, terrible days, they've had poor sleep, all these things, it's no wonder that these things stand out as injury risks. Let's think of it another way. If you're like we have home field advantage, for example. You know the field, you know how the turf feels, you know everything about it, you're comfortable in it, and you're much more likely to be highly coordinated because you kind of have the feel of what's going to happen on the field. Versus, you're playing an away game, it's a new field, maybe it's a new temperature, new environment. You're playing instead of, in the southern hemisphere where it's warm and pretty temperate climate for a lot of the year, maybe hot. Maybe you're going north. Now there's more rain, more snow. Different parts of your physiology are affected because you're not as warm as soon. Maybe the field is different. Rather than artificial turf, maybe you're playing on real grass. All of these factors are parts of this neuromuscular control or altered muscle recruitment patterns. I mean, if you have to borrow somebody else's equipment that isn't exactly fit for you for certain sports. So if you're if you're a hockey player and you're borrowing somebody else's skates who are a size too small now, you're not going to skate the same. You're going to have altered neuromuscular control and altered muscle recruitment. So this isn't a call to action to get people to do a bunch of balance exercises or a bunch of hyper sport specific coordination drills like juggling a bunch of balls off a wall for hand-eye coordination. This is, let's make sure that if we think a patient or an athlete needs to do all these fancy sport specific drills, walk all the way back to the bare bones basics to make sure that nothing like sleep, diet, and just levels of mental stress, environmental stress aren't the things that you need to address first, because that is the low-hanging fruit that you need to take care of. Because you could do all those fancy drills in the world, if you aren't taking care of the typically largest culprits, why bother? All right. So we're still talking about hamstring injury risk. We're still talking about neuromuscular control, but I'm going to bring it back to recover as hard as you play. Take care of the basics first. That typically will lead to consistent neuromuscular control and consistent muscle recruitment so that you're at less of a risk to deal with a hamstring injury. Okay. Now, consistency also isn't rigidity. So I'm not saying it's going to be everything every single time, because a field of play is a field of play. It's controlled chaos. So if you give your body enough consistency within a controlled level of chaos, That's what I'm talking about. But that might be a discussion for another time, because then we're getting into, wait, what are you talking about? What's the nuance? What's the cutoff? So I'll save that discussion for another day. Let's see, where was I? Prevention strategies such as Nordic hamstring exercises. So if we're actually working the hamstrings, not necessarily in isolation, but if we actually focus on them as part of an exercise group, it seems to reduce hamstring injury rates. And hip extension exercises have shown efficacy in reducing injury rates. Shocker, more robust tissue is more resilient. Basically, that's one way to put it. Compliance with the programs is crucial for effectiveness, and future research should focus on validating these strategies across more populations and having additional external validity to back up what we're saying. So if you didn't know about hamstring injuries, they're very common. There's a lot to what or who is at risk. And don't think if somebody's like, again, one more time to beat the dead horse. If somebody is watching you play or practice and they're really getting into like a hyper fixated, like, oop, that one movement right there is so out of whack, etc., you're probably actually going to lead somebody to having these issues because they're going to focus on something that was a non-issue. If you think your athletes are at risk because they aren't grooving the patterns on the field that you think they should be, it may not be that they need to run a whole bunch of additional drills to beat that pattern in there. Maybe we just need to make their tissues more resilient overall and focus on their recovery aspects like sleep and diet, and their risk factor will drop precipitously, and they may fix themselves. Like maybe the pattern that you think is off is now improved, or maybe the pattern that you still think is off, the risk comparison is so low now because you're taking care of them in so many other of the more meaningful ways that you're probably fine. All right. If that didn't make sense, hit me up in a comment, because I can ramble quite a bit, and sometimes I think I make sense, but then I play it back and it doesn't. So hopefully that makes sense for everybody on the other end. Last one. The impact of musculoskeletal pain on work functions and quality of life in office workers. I wanted to end this one because it's one aspect of the clinic that I want to highlight. By design, my clinic is low volume because I need to dedicate so much time individually to people. And that does lead into a bit of a conundrum insofar as how do I help as many people as I can in the Western Wisconsin area. And to that effect, we have really been bridging out and pursuing different employment-based musculoskeletal solutions, like corporate healthcare, on-site work, so that we can really get in where people are typically having these issues, whether it is injuries at work or injuries outside of work that are really impacting their jobs. So that is something that we are actively building and working towards to help the Western Wisconsin area. And that's why I wanted to end on this study, just and not necessarily as an announcement, because I've said it before, but just as a highlight, near the end of August, just, hey, again, reminder, we do offer this, we do have it. So if you're out there on the other end thinking, yeah, I know my workplace could use these services because we're having injuries, or we have so many people in pain, or we notice that productivity isn't as high as we'd want, reach out to us. But let's get into the study. Office workers will often experience MSK pain. Shocker, shocker. So how common is it, and what is its impact? Well, let's find out. So I'll admit this study isn't necessarily as strong because it's entirely based on surveys and questionnaires. So a descriptive study was conducted with 263 office workers. A personal info form, a work role function form, pain scale, and a short form health survey were used to collect data, and that's how they kind of got their results from it. So what were those results from the questionnaires? Among the 263 office workers, 70% basically reported pain in the neck, 50% in the shoulder, and almost 50% in the low back. Alrighty then. And 33% in the elbow. A strong negative significant correlation was found between pain intensity of the participants and what they scored on that work form. So how did they perceive their productivity at work, their work morale, etc. A moderate negative relationship was found between pain intensity and the physical component summary when they had that short form questionnaire, and the mental component summary and the workforce study subscales. And a strong negative relationship was found between that workforce study or the workforce survey total score. What does that mean? Basically, the more you tested to have pain, the worse you were testing overall as far as work ability and capacity. They sum it up probably better than I do. Office workers are most likely to suffer from neck pain, and this negatively affects their work functions and overall quality of life. And what stinks about the real world is we can have several different scenarios. You are actively in pain at work because of work. So it's your job, but you still need to do it because you need to make money. You're injured outside of work, but the pain is staying while you're at work. So now you have something outside of the work environment causing you pain, and it's exacerbated by your work, which is no fun. Maybe it's one of those things where you now have to figure out and navigate, is this a personal health issue that I'm not addressing? Is this a work comp related thing because of the environment of the work itself? There's so much that goes into it that I should frankly dedicate an additional video on what goes into workplace healthcare insofar as what is OSHA's role, what is work comp's role, what is HR's role, what is the standard operating procedure? Am I getting the healthcare that I deserve in this situation? But on the flip side as well, what do I need to do to set myself up successfully as an employee to make sure that I'm able to be employable long term? And I think that is a big factor that is overlooked. Is there's a lot that the employer has a responsibility to do. Don't get me wrong. They have a huge responsibility. But on the flip side, nobody really talks about the employee's responsibility. And I think that is greatly overlooked. And what do I mean by employee's responsibility? I do think that it is an employee's responsibility that should they want to have security in all facets of their employment, that they do everything they can to be as irreplaceable as possible. Now that sounds callous and cold, but let me explain. If you don't feel like you have job security because you feel like you're going to be replaced outside of motivational reasons, even though this plays a factor into it, you need to make sure that you are irreplaceable by upper management. A big factor of that when we're talking about these factory jobs is having the physicality to do the job. What I hear and see a lot is a lot of people will burn out because there is a chronic nagging injury that they no longer can perform the job, and so they're let go. Or they can, but it causes them such distress that they no longer want to. So I do firmly believe, and this is the mentality I had when I was doing all manual labor, that it is my responsibility to maintain my health so that I can do the job to the best of my ability in order to earn that paycheck and show that I am irreplaceable because I am a healthy, functioning unit in this work structure. So there is dual responsibility when it comes to discussions of personal health care from the employees, between the employees and the employer. So I will talk about both at some point. What is the employer's responsibility? What is OSHA's role? What is work comp? But we also need to address employees' responsibility because I've seen it too often. They let themselves go. They eat like campground raccoons. They developed type 2 acquired diabetes, and that really, really puts you at risk for work injuries, whether it's outside of work that impacts the job or you get injured on the job. And now, because of your influence into how much of a risk you put yourself into to developing an injury, you're now taxing the employer through a work comp injury that could have been avoided if everybody did their part. if the employer maybe helped facilitate the resources you need to maintain being healthy, and you putting forth the effort to be as healthy of an employee as possible, I think that's where we need to talk about this whole relationship thing. But I can ramble. It's getting late. I've talked way too long for 5 short studies. So until next week.